Hi everyone, this is Tim, your Block 3 instructor, and this PowerPoint is going to be based on patients with hematology concerns. It's pretty fast, pretty simple, and I'll try to make it easy as possible. So with anemia, it's lower than normal hemoglobin and fewer than normal circulating erythrocytes. It's a sign of an underlying disorder. Normal for men is going to be 13.5 to 17.5 grams per deciliter, and for women it's going to be 12.0 to 15.5 grams per deciliter. In the hospital setting, we're looking more at the sevens, eights, and nines for before we actually transfuse. Anything higher than that, it's probably going to be more diet related and probably can actually resolve itself. The first anemia problem is going to be folate. Folate deficiency anemia is the lack of folic acid in the body or the blood. Folic acid is a B vitamin that helps your body make red blood cells, and you don't have enough red blood cells, you have anemia. Pretty simple, right? Folate levels for adults is going to be 2 to 20 or 4.5 to 45.3 moles per liter. I show the picture here. To me, this probably makes the most sense. You actually have a red blood cell precursor. It takes folate to actually make the red blood cell precursor to thrive and to actually be a good cell. Will go through normal cell division, and then it becomes red blood cells as an end product. If there isn't enough folate, the cells is unable to divide, and it becomes a macrocyte. So there's where you go from having enough red blood cell production to not enough. And the folate does that. So what causes folate deficiency anemia? If you don't eat enough foods that have folic acid, these could be green leafy vegetables, fresh fruits, fortified cereals, yeast, and meats. If you drink too much alcohol, that would also cause the folate deficiency. You have certain diseases of the lower digestive tract, such as celiac disease. So you're actually not digesting, well, you're digesting, but you're not absorbing what you're digesting. This type of anemia also occurs in people with cancer. You can take certain medications, such as some used for seizures. The side effect is the inability to actually synthesize the folic acid. If you're pregnant, this is because the developing baby needs more folic acid. The mother absorbs it more slowly, and the lack of folate during pregnancy is linked to major defects that affect the brain, spinal cord, and spine, which is neural tube defects. So here's your symptoms. You have pale skin, decreased appetite, being grouchy or irritable, lack of energy or tiring easily, and you also have diarrhea and smooth, tender tongue. So for a patient to be diagnosed with this, your physician or yourself as the bedside nurse will actually take a medical history and find out if it's either genetic or if it's diet, medication. I mean, you really do more of a history to find out if there's anything that could be contributing to this. You also do the physical exam to actually see the symptoms. Your physician will probably order blood tests in order to determine what the folate level is and if there's anything else going on. And then they might also do a barium study, which is going to determine if there's digestive problems. Again, you can consume as much as you want, but if you're not processing it, then it's not really going anywhere. So for treatment, it's going to be vitamin and mineral supplements. You can change your diet, which is leafy vegetables, citrus fruits, beans, and whole grains. And you can also treat the underlying disease. The next one is going to be iron deficiency anemia. Iron deficiency anemia is due to insufficient iron. Without enough iron, your body can't produce enough enough of a substance in the red blood cell that enables them to carry oxygen. I put these two pictures on here purposely so that way you can actually see the hemoglobin itself is what carries the oxygen, but it takes iron to actually bind to both the hemoglobin and the oxygen molecule in order to actually carry it. So with iron deficiency anemia, again, it's more of an oxygenation problem than anything else. And keep that in mind because when we go further into this with the symptoms, it'll make a little more sense. So causes of this could be blood loss, the lack of iron in your diet, or inability to absorb iron, and also pregnancy. So this is where the symptoms from the lack of having iron to bind to the oxygen molecule for the hemoglobin to transport. So if you don't actually have, I mean, you may actually have enough oxygen in your system, but not necessarily perfused oxygen. So that iron is what actually attaches to it to be able to carry it. So without the oxygen being used as much as or as efficiency as possible, you're going to have extreme fatigue, you're going to have weakness, you'll have pale skin, you'll have chest pain and a fast heartbeat or shortness of breath, and that's because of the fact that you aren't getting enough oxygen perfused. Your heart will actually speed up to be able to take what it does have and make it work as efficiently as possible. You're going to have headache and dizziness and lightheadedness, which makes sense because if you don't have enough oxygen to your brain, then you're going to be dizzy. You're going to have cold hands and feet. That's probably because it's probably trying to condense the blood that you do have into more of your core area as opposed to the extremities. Inflammation or soreness of your tongue. You'll have brittle nails. You'll have unusual cravings for non-nutritive substances such as ice, dirt, or starch, which is very interesting because I've actually had several patients that I see them eating and chomping on ice all day long. And if you actually look at their lab work, they tend to be anemic. I'm not sure if this theory has ever been proven, but I have read other stories and other things about the difference between the chewing the ice and the anemia. You also have a poor appetite, especially in infants and children with iron deficiency anemia. So for diagnosis, you're going to do a medical history. You're going to do a physical exam to be able to see the signs and symptoms. Your physician is going to order some blood work to determine what the iron level is, and they're also going to do a barium study in order to find digestive problems to make sure that you aren't having a absorption issue. Treatment is easy as choosing iron-rich foods such as meat, pork, and poultry. You can also do seafood, beans, dark green leafy vegetables such as spinach, dried fruit such as raisins and apricots, iron-fortified cereals, breads, pastas, and you can also do peas. So choose food high in vitamin C. This allows the body to actually absorb the iron. It's almost, when I read this, it made me think of vitamin D and calcium. The two together makes it actually absorb better and makes it work more efficiently. This is the same thing. Vitamin C and iron together actually make the iron work better. We also have pernicious anemia. Pernicious anemia is defined as a type of vitamin B12 deficiency that results from impaired uptake of vitamin B12 due to the lack of a substance known as intrinsic factor, or IF, which is produced in the stomach lining. This is related to a decreased oxygen carrying capacity of the blood, which can include tiredness and shortness of breath. Vitamin B12 deficiency also interferes with the function of the nervous system, and symptoms due to the nervous system damage may be apparent even before the anemia is discovered. When I was reading the information on this, I think that most people can go very long amounts of time before they realize that they're vitamin B12 deficient. Your body actually stores it for a very long time and only uses what it needs. So until you actually find out or start having the symptoms, it's been a very long time since you've had this problem. The intrinsic factor is a protein made in the stomach that's necessary for the absorption of B12. So you can consume as much as you want, but if the intrinsic factor is not really there, then it's not actually doing any good. Symptoms of pernicious anemia is feeling tired and weak, tingling and numbness in the hands and the feet, and a bright red smooth tongue. And that kind of makes sense. If you're not absorbing B12, then you're going to be lack of. And again, this is what is used to actually carry oxygen. It's to help with the iron and the folate. So again, like I said, if you're missing this, then you're going to be tired and weak because of the anemia. For diagnoses, you're going to do family history because this can often be more genetic. You're going to do a medical history. You're also going to do a physical exam, and you're going to run some lab work. Here's a picture of pernicious anemia. So again, the vitamin B12 cannot be absorbed because of the lack of intrinsic factor, which is the protein found in the stomach. So for treatment, easy to treat with vitamin B12 pills or shots. You do diet changes. Lifelong treatment is needed. So this almost kind of doesn't make sense, but try to keep it simple. So when I first did this, I thought, well, wait, why would you take vitamin B12 pills if they're not being absorbed in the stomach? So it's the intrinsic factor itself is what breaks down and helps absorb the B12 from the foods that you eat. The pills can actually be absorbed differently, and the shots can also be absorbed into more of the bloodstream as opposed to being broken down to the stomach. Diet changes, I say this because of the fact that some people just don't eat well, or they don't eat healthy, or you have vegetarians that don't know enough about their diet to keep them healthy enough to make all this work. So a lot of times it's really as simple as just introducing new foods that actually have B12 in them. Lifelong treatment is needed because there isn't actually any fix for pernicious anemia. So if you don't have the intrinsic factor to break down the B12 and have it be absorbed, then whatever you do to get the B12 into your system is going to be lifelong. Doctors don't know how to prevent pernicious anemia, and is caused by an immune system destroying the stomach cells. This is more of an autoimmune problem. The next we have thrombocytopenia. There are not enough platelets in the blood. Platelets help blood clot, which stops bleeding. A healthy person usually has a platelet count of 150,000 to 400,000, and you have thrombocytopenia if the number falls below 150. So makes sense, right? The first thing is we have idiopathic thrombocytopenia, which is also known as immune thrombocytopenia, which is the most common causes of low platelets in people who do not have symptoms. You may hear of it referred by its old name as idiopathic, and again, this is more immune thrombocytopenia than anything else. So basically, it's just the fact that you have low platelets. Causes can be infection, which is viral infections such as chickenpox, the parvovirus, hepatitis C, Epstein-Barr, and HIV. It can also be caused by sepsis, a severe bacterial infection in your blood, or it can be caused by Helicobacter pylori, or H. pylori, a bacteria that can live in your digestive system. It can also be caused by medications. Medication side effects including drugs for heart problems, seizures, and infections. Their medications can be heparin, a blood thinner used to prevent blood clots, or it can also be chemotherapy. Medical conditions such as blood cancer, such as leukemia or lymphoma, alcoholism, pregnancy, your spleen might actually be taking all the platelets and destroying them. It could be rheumatoid arthritis or lupus, and maybe your body is using too many platelets, which we'll get into a little bit later. Symptoms, you're going to see bleeding, bruising, and petechiae. So the first top picture, the small bruises is the petechiae, and the larger one is the purpura. So if you look at the oral picture, that's the petechiae, and then as far as the one that's more further to the right is more bruising caused by bleeding. In order for diagnosis, you have thrombocytopenia is often found by chance when your doctor does a routine blood test. He or she may ask you certain things like, what are your symptoms, including bleeding, and have you noticed them anywhere else? When did you first see them? Does anything make them better or worse? What medications and supplements are you taking? Have you had any shots in the last month? A blood transfusion or use drugs with a needle? And does anyone in your family have a problem with their immune system, such as bleeding or bruising? And what have you eaten recently? So a lot of these things, once the doctor finds out the culprit, it might be not necessarily be a immune problem or an autoimmune problem, or might be more of what either you're taking or what you're actually eating. So the physician will order some blood work, such as a CBC, measures the number of red blood cell and white blood cells and platelets. They'll also do a blood smear, which shows your platelets look like under a microscope. It's very interesting because I have a friend who had rotator cuff surgery, and before they do surgery, a lot of times they'll do blood work to make sure that you're as healthy as you possibly can be in order to do the surgery. And they found that everything was fine except for his platelet count, which was extremely low, like 50,000 low. And he was very worried. And I had told him, I said, what's really interesting is that I don't see any bleeding or bruising or any symptom of you having low platelets. So they referred him to an oncologist, which made him even more worried. And he got there, and the doctor had talked to him and told him the exact same thing I had said, that they didn't see why, based on the lab work, they would think this, other than the fact that his platelet count was severely low. But again, just looking at him and doing an assessment, you didn't see any bruising or bleeding. So the oncologist had recommended that he get his platelet count redrawn, but this time they're going to draw it in a different tube, and that different tube allowed his platelets to not clump together, which is what was happening during the first blood draw. And it just naturally clotted, or not really clotted, it actually naturally clumped, and they couldn't read the amount that he actually had. So doing it in a different tube with different additive to it made it read a little bit easier. So now that he knows that, when he has surgery again, which was the second shoulder, they were able to do it, and they did it correctly. So the blood smear really will do more than just you do a CBC, you do BMP, you can do all these lab works, but when you do a smear, it makes it a little more accurate. They might also do a bone marrow test, or for diagnostics, a very fine needle is used to draw a small amount of liquid bone marrow and check it for cells that may not be working right. Or a biopsy using a different kind of needle to check the types and numbers of cells in the bone marrow. So the picture is basically a patient lays on their side, they go through the iliac crest, basically they bore this needle into their hip until it gets to the bone, and then they kind of turn it like a wine cork screw until they get enough or go deep enough, and then they basically unscrew it out, and then they pull it all out. So I've seen it done. It's very painful. We try to mitigate them as much as possible and make them as comfortable as possible, but you get all the way down to a bone, and now you're screwing into it. It's just, there's not enough pain medication unless we knock you out. But they do this at the bedside, so they're not going to do that. All right, so for treatments, they could do corticosteroids such as prednisone. They could do surgery to remove the spleen if this is a problem, because again, the spleen can gobble up all the platelets, and you can live without your spleen. They could do medication such as rituximab, IVIG, which is intravenous immune globulin. They can also do RHOD, which is immune globulin for those who are Rh positive, and they can also do platelet growth factors. I don't necessarily need you to memorize the medications, but just to be aware of the fact that medications is something that could be the reversal of having low platelets. Other treatments, so eat a healthy diet with lots of fruits and vegetables, especially leafy greens, to give your body the nutrients it needs. Avoid foods with quinine or aspartame, like tonic water, bitter lemon, or bitter melon, some diet sodas, and sugar-free foods, because aspartame is the sweetener that's added instead of sugar, and those could actually make your platelets go low. Don't take medication that makes bleeding easier, such as aspirin or ibuprofen. And again, don't drink alcohol. Alcohol actually thins out your blood. So if you're already having low platelets, you don't need it to be any thinner or less ability to clot. Another disease process is heparin-induced. Heparin-induced thrombocytopenia is also known as HIT. It's a complication of heparin therapy. There are two types of HIT. Type 1 presents with the first 2 days after exposure to heparin, and the platelet count normalizes with continued heparin therapy. Type 1 HIT is a non-immune disorder that results from the direct effect of heparin on platelet activation. So basically, you have a patient who has, let's say, a PE or some sort of DVT, and you put them on heparin, or you give them heparin injections, and because of that, the side effect is heparin-induced thrombocytopenia. Type 2 HIT is an immune-mediated disorder that typically occurs 4 to 10 days after exposure to heparin and has life and limb-threatening thrombotic complications. So basically at this point, you're clotting all over your legs and your arms, and it's actually cutting off the circulation to a point where you're actually going to lose them. HIT is generally not marked by bleeding, instead venous thromboembolism, or DVT, and a pulmonary embolism, and is the most common complication. Symptoms. So symptoms will present to where the thrombus is. So you either can have a DVT or a PE. And essentially it really can happen anywhere. And you're going to see symptoms based on where it's actually happening. So even though I put one in the leg or one in the chest based on these pictures, it can be your brain, it could be your kidneys, it could be your intestines. I mean, it really can essentially just be anywhere. And based on where it's cutting off the blood supply is what's going to cause that localized pain and those localized problems. Diagnostics. First, the timing of the onset of thrombocytopenia. In most patients with HIT, the platelet count decreases and begins 5 to 14 days of heparin treatment. Second, the severity of thrombocytopenia is usually mild to moderate, with platelet counts only rarely less than 15 times 10 to the ninth. And then third, the occurrence of large vessel venous or arterial thrombosis in association with thrombocytopenia. Thrombosis precedes thrombocytopenia in the up to 25% with patients with HIT. So prognosis, the complications can be DVT, PE, myocardial infarction, occlusion of limb arteries, possibly resulting in amputation, a TIA or a stroke, skin necrosis, or end organ damage, such as the adrenals, the bowels, spleen, gallbladder, and hepatic infarction and renal failure, and ultimately leading to death. So, what to do? You're going to discontinue all heparin products immediately, which sounds like a no-brainer, but it's really true. Platelet transfusions should be avoided with someone who has heparin-induced thrombocytopenia. They found that you want to do that more either emergent, oh my gosh, they're bleeding to death problems. Instead, you want to use something not necessarily quicker, but more that's just better, which is the vitamin K. You also want to avoid warfarin or Coumadin, and then you also can give them alternative anticoagulations, which is the next two drugs, which is bivalirudin and argatroban. Those two you don't necessarily have to memorize, but I just want you to be aware of the fact that there are medications that you can give to thin out the blood based on the fact that they're having blood clots. So the next one is thrombotic. Thrombosis is the formation of a blood clot inside a blood vessel, obstructing the blood flow through the circulatory system. When a blood vessel or a vein or an artery is injured, the body uses platelets or thrombocytes and fibrin to form a clot to prevent blood loss. So again, this is not heparin induced. This is not anything other than the fact that you have bumped yourself, you've caused some internal bleeding, and the platelets and fibrin is actually causing a clot in order for you to stop bleeding. Thrombocytopenic purpura is a rare blood disorder characterized by clotting in the small blood vessels of the body, resulting in a low platelet count. So the way this works is the fact that let's say I hurt my leg really bad and there's no actual skin broken, but I've actually broken some blood vessels within the leg. The platelets are going to cause, or it's going to go to the site of injury and actually repair it. You are now low on platelets circulating because of the fact that they're doing their job based on where the actual incident had happened in your body. So for this one, it's actually a lack of low platelet count because it's doing its job somewhere else. Secondary thrombocytopenic purpura has been associated with the use of certain drugs, including chemotherapy drugs. So symptoms, you can have neurological manifestations, including alteration in mental status, seizures, hemiplegia, paresthesia, visual disturbances, and aphasia. You can also have fatigue, which may accompany the anemia. You can also have severe bleeding from thrombocytopenia, which is unusual, but although petechiae is common. So basically, you can, because the platelets are doing its job in one area, doesn't mean you can't bleed to death from some other area. So. Diagnostics, laboratory studies are going to be CBC, platelet count, blood smears, coagulation studies, bun and creatinine. You're also going to do serum bilirubin, lactose or lactate dehydrogenase. Imaging studies and biopsies are not required for the diagnosis because they're not really going to see much. So, Oh, that's it. So a very quick 24 minutes and 46 seconds. I ran through them very quickly because you should have at least read these in your book. This was more of just kind of breaking down the highlights, which is, again, basically what is the disease process, what are the symptoms, what are you going to use to diagnose them, and then interventions and how to actually fix it. So anyways, if you have any questions, let me know and bring them to class.